My name is Jens Chapman. Today is October the 5th, and I welcome you to the SSF group here. Our conference room is holding the STED Talk, Spine Technology Education Debate Discovery, and I'll add to this an R, reflection. It's a joy and a privilege to get to reflect on our accomplishments, learn from our failures, and move forwards. And again, today we have a particularly cool topic, and it's actually one of our own. We rarely do that, but I think there's so much happening here that we do want to share that on occasion. We'll have our usual case presentations, and the main lecture today is from our own Dr. Oskouian, our chief of our spine service. We're going to talk about lower lumbar corpectomies in a variety of situations, and this remains a major obstacle and problem in our daily care. And these are always special stories, and we don't have any simple pat answers for how to treat those. And as you probably know, Dr. Oskouian is one of the three major innovators in terms of far lateral approaches to the lumbar spine. And he again has taken this as a study opportunity to try to really move forward. I want to thank Spine Art for the generous support. And again, I think we have 4 case presentations that illustrate the various challenges, and we'll discuss what we're dealing with and what our thought processes were. And in the chat room, I'm going to follow everybody in terms of comments or suggestions. So good morning, everybody, again. Good morning, Rod. Thanks for doing this today. And I think we're leading off with Dr. James Hicks, who's going to give us a case, and I think it's a burst fracture. Is that right? All right, James, come up.
All right. So we'll hit the ground running here. Jim Hicks, one of the spine fellows here at Swedish. So Miss S, she's 72. She has a history of osteoporosis with a fall. In September, she's diagnosed with an AO-A2 type compression fracture of the L4 vertebrae at that time. She's followed for close to 9 months with persistent symptoms. And then ultimately, she cannot tolerate more than 20 minutes of ADLs. And again, that's after 9 months of non-op treatment and following this fracture of L4. And her main issue is mechanical back pain with these ADLs and right lower extremity pain in addition to that. So eventually, she's diagnosed with symptomatic non-union of L4. This is her examination. Relatively benign here, although she does have some decreased right L5 dermatomal sensation. So on imaging, this is her original film, and at first it doesn't look particularly worrisome, but as you can tell, what may slightly differentiate this compression fracture from a complete burst, it's more of an A2 type, so it's more a classic pincer type lumbar fracture, and that the posterior wall of the vertebral body is actually mostly intact there. So something to look out for is this pincer type L4 fracture. And this is what she develops over time. This is, I believe, about close to 6 months after her injury. These are the plain films at that time, AP and lateral here. And then more impressively on the CT, you can see really what's going on here. So this is somewhere around 6 months after the diagnosis of her fracture. Again, she's having continued pain with her ADLs. And just a quick note on these pincer fractures, these AO-A2 types. With the fracture, the disc material interposes itself in the fragments, and this is kind of classically known since the 90s. There's several papers really not giving a percentage of the rate of non-union, but saying that it's commonly known that this can go on to non-union or have delayed healing. Again, the disc material interposes itself in this split coronal fracture. I think on the next slide, I have our solution to this. Is there anything that you all want to bring up prior to?
I think that's That's a great first discussion. Go back again to the first slide. So what was the time interval of the first presentation where there was a known fracture?
So September of 21.
So can you show us that first X-ray again? So what was the time interval of this? Wait, wasn't there an earlier one, or did I kind of space out on that?
So this is the first X-ray.
Okay, got it.
This is
Okay.
the injury film.
Okay, so let me ask you the following question. First, what was the time interval of this until the full collapse? How many months or weeks?
So she was followed for close to 9 months before the decision for surgery,
Okay,
but we knew that she was having difficulty healing around the 6-month time frame.
so 6 months. Was there a CT scan obtained at this point in time?
So around, it was between February and March, so around the 6-month time point. Where's
Okay,
that
so there was
CT
no
is actually.
CT scan obtained at this point in time.
Right.
What was your determination of the bone density on the CT scan in a non-involved vertebra like L1? Did you calculate that per chance?
So I did not, but her diagnosis of osteoporosis was actually during the attempted non-surgical management of this fracture. So in March of actually this year, so being about 5-6 months in, she was actually put on Forteo for osteoporosis.
Okay.
So her actual diagnosis of osteoporosis wasn't until after this.
So for
this
me,
fracture.
this is one of those great learning opportunity cases for all of us. And all of us who do spine care, whether we're neurosurgeons or orthopedic surgeons or physiatrists, should kind of participate together with every other care practitioner. And that includes radiologists who can call out this, and ER doctors who can set the right referrals into motion, and primary care doctors who can help implement care. This should be identified as an osteoporotic/osteopenia or a vertebral insufficiency fracture. And there should be an almost algorithmic kind of a care package put into place, i.e. a CT scan first. Was a brace applied? Was an LSO put on when this was first diagnosed?
I believe so, but
she had an LSO put on.
she was not wearing it all the way out to the decision for surgery.
Yeah, but initially she had at least that put on. Did she have a early recognition, as far as you could reconstruct, of an osteoporosis workup initiated, like a DEXA scan without the spine or something?
There was an early referral to endocrinology,
Okay.
but I think it just takes a while to get in.
I mean, so for me, the missed opportunity here is at this point in time, and the data is becoming more and more dense on this, a vertebral augmentation procedure with bone cement would have been a fantastic first opportunity, because probably whatever we're doing next could be averted at this early stage. And the warning sign radiographically here, I think you pointed out, is that both end plates have cavitated in.
Right.
So the upper and the lower end plate have gone in. So this is not your usual little compression fracture. This is actually something, as you had correctly identified, more complex.
Yeah.
Rod, what were you involved?
I agree, Jens. And what's interesting is that I think that the management is of this fracture acutely is super important. So just like Dr. Chapman said, I think you got to get a CT. And then I think if you don't do a kyphoplasty or a vertebroplasty, this is bound to fail.
Yeah.
And we don't do, and it's interesting because if you look at the traditional algorithm is people do it for pain. We actually do it so that you don't get deformity, so you don't end up getting open surgery. Because we know, I mean, this is there's no way.
Progressive issues.
Yeah, I mean, if you get a CT scan and you see how bad of a fracture is, I think that's kind of what our algorithm is, and it works great.
Yeah, I think.
Yeah, Dr. Huang from the University of Arizona. Good morning, Robert. Thanks for joining us. So he again said, what's the role of bracing, osteoporosis treatment, early kyphoplasty? Could not agree more, Dr. Huang. And again, this should be on almost autopilot. And ideally, the ER doctor, I'm not blaming anybody here, would refer a patient automatically towards this kind of an algorithmic treatment, because an early recognition, early intervention can avoid a heck of a lot of secondary things. And again, that also goes towards postural treatment, gait training, fall prevention, things like that with PT. And without a question, and again, this actually comes from the Seattle area, early kyphoplasty actually now in the more recent past has been shown to be substantially better than not. And that is from our own Dr. Neil Schonert down the South Sound area, who actually managed to get Medicare payment for early vertebroplasty. It's actually the preferred treatment now for early osteopenic fractures. So,
Yeah.
All right. So now we have a mess, and Dr. Hart is here. So Dr. Hart, how much kyphosis does the lumbar spine tolerate? I've always heard and was taught, hey, the lumbar spine's forgiving. There's a lot of canal space, and the spine can compensate for a loss of lordosis. So when do you ring the alarm bells? Is this an already concerning alignment, or is this still an acceptable alignment? Can the body compensate for something like this?
In this particular case, I think the alignment so far looks okay. So the alignment is not currently an issue on the images that you just showed. But so in other words, if it heals where it was, this would be fine. But these images are rather ominous. The CT on the left in particular suggests something that is no longer vertically stable. And I have to say, I mean, this case is bringing back some personal memories for me. My father-in-law was a stubborn old surgeon himself, and got a compression/burst fracture. Actually saw the spine surgeon at his institution who recommended kyphoplasty early, but as a skeptical older surgeon, his opinion of spine surgery was not that high, and I don't think he understood the difference between what a kyphoplasty or vertebroplasty or an open surgery really is, and he denied it. And he persisted another 4 or 5 years, but he died with an extremely kyphotic spine and a neuropathic, neurogenic bladder. So these are potentially really impactful injuries, and the early intervention is so small and so limited in terms of its complication rate. It's to me, it's a no-brainer.
And I do want to recognize Dr. Schauner's contribution was actually from a private practitioner who did a very large data registry in a geographic area in the South Puget Sound area, so that's south of us in Tacoma and Puyallup. And the data was so convincing on a large scale. So this is efficiency and efficacy combined that the federal government actually decided through our local payer arm to actually make that the preferred treatment. So now we have a mess. So what do we do? And Dr. Ahmed Najjar, thank you for calling us out on this. 2 levels above, 2 levels below. That's a standard for burst fractures for most cases. So what you say?
So this non-union, we did address aggressively. We did do a 2-stage procedure, a single day. So that was an ALIF approach, placing this cage anteriorly after debridement of the non-union and graft placement. So restoration of height, stabilization of that anterior column, some indirect foraminal decompression, which you probably needed. There was use of navigation posteriorly. We did utilize that for some soft tissue preservation, given her osteoporosis, and just going one up and one down, really preserving her soft tissues there. We did utilize cement at the top level and bottom level of this construct. And we did fuse the facets posteriorly as well, using the navigation.
So the indication here was structural continuity of a bony column. There was no neurologic indication, and there was a modest structural in terms of alignment indication. Is that right?
So she had progressive deformity. She had some L5 sensory issues on the right, and then her mechanical type pain was concerning for us during her ADLs.
So you come from a proud institution with a great trauma program and many other great programs, the University of Alabama. What were you taught to do for a burst fracture?
Most time you put them in a brace and get upright films, unless you see 20 degrees of focal kyphosis or you see gapping posteriorly on a CT. Then you get an MRI and then assess the posterior.
And now if you have a failed burst fracture treatment, what would the surgical kind of outline be? What do you usually do?
Yeah, so I think you look at the overall parameters to decide, okay, is there deformity that needs to be corrected? And I think you start getting 9 months, a year out from things like this, you got to assume there's going to be some kyphosis like you all mentioned. I think we would try to do a lot posteriorly if we could. If it needed an ALIF, we would certainly consider that as well.
And how was this anterior cage applied? Was this an open standard retroperitoneal exposure?
Yeah, so we did with vascular surgery assistance, the way her anatomy was is actually very nice. All her vessels were able to be moved to her right fairly easily, and we had full access to this vertebrae. It was actually very nice.
And why is it such a great vertebra to talk about specifically in terms of the bifurcation? What's the problem with that?
Right, so it's right there. And so in her case, the anatomy was slightly different, which helped us, but it's always important to look at the anatomy.
So it's a question of a high versus a low bifurcation. And there's also a certain vein that's sitting right there that may hamper your access. Do you know what I'm thinking of? One of those great questions.
I know L4-5, you worry about an iliolumbar vein.
Iliolumbar vein, bingo, that transverse little killer vein that can be quite big. How did the patient do? 1 month out, so far so good?
She's doing great. She's maintaining her alignment.
Yeah.
And mechanically, she's doing much better getting up. Obviously, she was sore after surgery, but her mechanical pain has improved.
So Rod, what do you think about this case? This looks pretty nice, but is this, as a board reviewer and neurosurgeon, would you accept this if a candidate would show you this, or is this kind of an outlier solution?
I think it's reasonable. You know, again, I think you have to kind of weigh all the risks, the approaches, study the vessels, and see, you know, what that looks like. I think you could, you know, if the patient was really sick, I think you could just do posterior only as well.
Yeah.
But it has a higher.
Hey, Jens, can you hear me?
Yes, I'm here. Fire
Hey,
away.
thank you. I just wanted to chime in because this was one of my cases. And, you know, when I saw this on imaging and I actually saw this lady on a Zoom call, I was thinking probably more along the lines of L2 to pelvis. But when I met this woman in person, she was actually very cachectic. So we sent her for nutritional consults as well. And I was concerned about her soft tissue envelope and doing a posterior approach, whether she would be able to heal. So that actually played a pretty big factor in wanting to do a less invasive posterior for this patient. So fortunately, she's done well. You know, I definitely had a different plan in mind, just looking at the imaging versus actually the patient herself. And again, I think that was a big factor for her. I was very concerned that she would be able to heal. She had a BMI, I think 17 when I first met her, and actually postponed. She was able to gain some weight before we approved the surgery.
That's a good point.
I think this is beautifully done, Amir. This is really looks beautiful, very smart decision-making. The only thing is obviously how much will her bone above and below hold out? And no, I think this is very, very clever. I really like this answer. What are your thoughts? And we can also ping that to Dr. Hart, who's published on this. What do you think about insulating the vertebra above and below for a incipient fracture, like specifically at the L2 level, so one level above your rostral instrumentation level, against a fracture?
You know, I've considered that before. I would say probably in a longer construct, like if I was doing L2 to pelvis at L1, I think it would be a much longer lever arm, and probably a lot more likely to be an impending fracture. Again, I just don't know where to stop. Do you do 2 above, 2 below, 1 above, 1 below? You know, we've seen them fracture regardless, you know, in terms of the underlying pathology. So I think it's definitely reasonable. But for her, because it was a shorter construct, I didn't feel like I wanted to be as aggressive.
No, I think this is a very, very good case to show, because as you had said, the length of lever arm in an osteoporotically challenged patient magnifies the failure points at the upper and lower ends of our constructs. And the shorter we can go, the better, actually. So it's actually a really smart thing. Dr. Hart, so you've published and you're heavily quoted on this paper. Last I checked, it had like 120 quotations on that. Cementing above and below a construct, does it help or not? You used a financial analysis model to provide insights. What are your thoughts now, looking back 10 plus years?
Well, it's always nice to find out that actually somebody has read your work. So thank you for that shout out, because it's not always clear. That paper actually, and it's always kind of felt like a tree falling in a forest and nobody was really around to hear it. So I don't know, did anything happen or not? But yeah, what we showed was that it reduced the fracture rate, and it did make economic sense when you compare the cost of a bigger revision surgery to the cost of a prophylactic kyphoplasty. At that time, you couldn't bill for this as a procedure in an unfractured vertebrae. So, yeah, I having said all that, I agree with Amir. I don't think we really have a sense of protocol of, where do you stop? I think this construct in particular, sort of in mid-lumbar spine, besides the length of the construct, as we've already called out, the location of the construct matters. So thoracolumbar junction is much more vulnerable than mid-lumbar. So for me, this construct, I really like not doing further augmentation beyond the upper instrumented and lower instrumented vertebrae, because they're both pretty horizontal.
Yeah.
I think their vulnerability to fracture here, not zero, but most likely this lady gets through this treatment successfully.
It's a great case, very interesting. So a little self-advertisement. We have some great courses coming up here at SSF. And this pointed one here, and this is where I'll ask you to pull this case out again, because then you'll have 3-month follow-up, and we have some leading osteoporosis specialists coming. That is our trauma course, December 2nd and 3rd.
Yeah.
And we'll have Dr. Schnake from Germany, the president of the German Spine Society there, who has actually developed a osteoporosis score.
Yeah.
So,
Right.
so show it again.
Yeah, definitely.
All right, thank you. Next up, we have Dr. Abe Schlaudraff, who is dressed in fashionable gray, sporting another fall look at SSF.
Just trying to keep up with Jimmy. All right, so I'm talking about a somewhat similar case, but different. Someone had a 67-year-old gentleman had a spinal metastasis, secondary prostate cancer. Was originally seen in our clinic, and at that point recommended surgery. I'll show you guys the films at that point. He had chronic low back pain with acute exacerbation, also had lower extremity radiculopathy, and issues with being able to ambulate. He deferred surgery. 1 month later, he presented to the emergency department action with worsening pain and increased ambulatory issues where he could no longer walk, and some early cauda symptoms. You can see there in his lower extremities, he has a fair amount of weakness, primarily on the right lower extremity, but also in the left leg. Reflex is overall normal. Here's the original presentation, imaging 1 month pre-op when we originally presented to our clinic, recommended surgery. You can see there that he has, again, an L4 pathologic fracture from renal cell with some retropulsion, some central stenosis, foraminal stenosis as well. At that point, he decided to think about it, didn't want surgery, came back a month later and see progression of that pathologic fracture with more compression, deformity, and more central stenosis, foraminal stenosis. At this point, given that he had pretty significant weakness in his lower extremities as well as early bowel and bladder dysfunction, he elected to proceed. So we moved forward with a 2-stage surgery. Any questions or anything you want to bring up before I go into the...
So again, just quickly, we want to always make sure when we present infection and tumor patients, what the workup profile consists. So what do you do as an imaging workup to do due diligence for staging?
Body CT, bone scan.
Bingo, yeah. So we image the neural axis, preferably in CT and MRI scan. And we look at chest, abdomen, pelvis CT, and we do what brain imaging as a neurological surgeon, as a screening tool? Do you recommend a CT or an MRI with contrast? What should we do as a MRI? Because that's chains something.
Yeah, thin sliced MRI with contrast is probably what I do if looking for brain metastases.
Okay, all right. Is a CT acceptable?
I don't think so. I think there's, especially if you have a small metastases that's sub 5 millimeters, you're not gonna be able to pick that up on a CT per se.
Okay.
So I think MRI with contrast is probably the ideal study.
And in brain mets, what do we look for in terms of decision-making of a reconstructive spine surgery? So what's a clear kind of a large exclamation mark to not proceed in your book?
So if someone has one brain metastases that's less than 3 centimeters, a lot of times someone might do stereotactic radiosurgery, although open surgery has primarily been the mainstay for treatment of solitary brain metastases. If you have several, then you can do stereotactic radiosurgery. It varies on how many is the limit between stereotactic radiosurgery and whole brain radiation. I've seen back in my previous institution treating up to 12 lesions or so with stereotactic radiosurgery, although it's a long treatment course of about 3 hours in a Mayfield clamp and being immobile. But once you get higher, then you think probably whole brain, and depending on the burden of disease and how far the metastasis burden is, and whether or not it's responding to chemotherapy, I think kind of you have taken the gestalt of all that.
That's a great brief outline. And talk about the role of a metastasis, of a metastatic disease, of a biopsy in this kind of a suspected metastasis situation.
Yeah, so this was a fairly new diagnosis. So I think getting a biopsy is very reasonable, especially if you have a solitary lesion or you don't have any previous lesions. I think going somewhere that's less invasive, like a vertebra, I think is a good, easy place to biopsy. Sometimes with brain malignancies, we'd have no metastases elsewhere, and we think maybe it could be a primary brain tumor like a glioblastoma, and we resected some metastasis, and that's the first metastasis they've had. So I think going for an area where it's relatively easily accessible, like a lot of times the lung you can get either with a CT guided biopsy percutaneously or going endoscopically with interventional pulmonology, I think are good ways to go.
Good. So, Rod, what were your concerns here? So, how much to do surgically, embolization, bleeding? Tell me a little bit about what went through your mind as you're thinking about this patient.
Yeah, I mean, I think embolization is always helpful with metastasis, and obviously, you have to consider, this patient's probably going to get radiation and chemo. So, the wound management, nutrition, all those play a huge role in deciding what surgery you end up doing.
Good. All right, so move forward. What happened?
All right, so it was a combined case. Stage 1 was Dr. Chapman. I did a posterior L2 to pelvis instrumentation and L3-4 laminectomy. Also from L4, from the posterior approach, I took down the pedicles and part of the posterior vertebral body as much as was accessible. You can see that based on the sagittal and axial CTs, and there you can see films, x-rays, interop before the next stage procedure.
So the purpose of the surgery was what?
Stabilization.
Stabilization,
So it's posterior
neurological.
stabilization, neurological decompression, prior to going in and doing anterior column reconstruction with the stage 2 with the cage reconstruction.
So tell us about one or two different scoring systems that either used at Penn State, one of our great nation's institutions, or what you're going to use in your own practice to kind of risk profile patients, see whether they could benefit from a surgery or not.
Yeah, so I think SINT score is probably one of the better ones that I use. I think it's pretty robust.
Do you know what this patient qualified as or what the numbers were, roughly? I think it's written in the chart, but
I imagine it's probably more than 13.
I think it was in the intermediate range.
Yeah.
Present by memory, high intermediate range. So
High intermediate range, but they have cauda syndrome, so that's kind of pushed you over the edge.
yeah.
Yeah, if they were asymptomatic, didn't have weakness, bowel bladder dysfunction, I think,
Okay.
maybe way
And
through radiation.
what was done in terms of cementing again? So what's
So you cemented 2 levels above the fracture and 1 level below, and then nothing down into the pelvis.
and what's going on with those rods? Are there what's that rod construct look like to you? What do we do there?
So quad rod construct across the lamine where the cage was.
It's in anticipation of no bone healing or limited bone healing because this patient would get radiated. There was
Yeah.
an extra effort at securing this patient metal-wise. Dr. Hart, so in terms of, you have instrumentation. So I see a lot of rods that are just kind of clipped to the side of another rod with kind of side connectors. Is that as good as having this kind of a 4-rod construct? Is there a mechanical difference? There are 2 separate anchoring points here. Is there an advantage to doing this, which is an extra hassle? Or does this kind of a clip-on rod on the side that bypasses the main weak spot provide sufficient mechanical strength?
Well, this is, I don't have a vocabulary for this to the extent that you do. I think the work you're doing on really categorizing and classifying the various rod patterns is going to be very valuable. This to me, I would call these satellite rods because they're separate from the main construct. So my vocabulary is limited to outrigger versus satellite rods. This is a little bit kind of in between because the construct from L3 to L5 is clipped onto the main construct by a cross connector, it looks like, or it looks like a U-shaped domino. I don't know. The truth is, I think we are still early on in understanding the biomechanics of this, but clearly it's improving our at least the durability or the length of time that a construct lasts prior to failure. It's stronger, it has to. I think it's necessary in many of these cases. And I do think this kind of construct, the satellite construct, I use, for example, in 3-column osteotomy. I have said, I think this changes the biomechanical environment of the small construct that's bridged off of the main construct, because it takes what would otherwise be, if you had this all on one rod, the forces would be distributed throughout the entire construct. Here, it takes that middle portion at least and changes it into essentially a 1-level or a 2-level fusion in this case, and moves it off of the main construct. So not only are we hoping, a 2-level TLIF essentially, or a 1-level corpectomy will heal, which it typically does if there's not anything above and below it instrumented. In this case, you've not only got that construct, you've got a protective construct above and below it. And so I think the chances of healing here are really very high.
Thank you. That's a great discussion. Dr. Oskouian, so we came to you, and our partner, Dr. Abdul-Jabbar, just showed a beautifully done corpectomy with an open procedure. And we came to you because you're the master of far lateral procedures and said, can you help us with a less invasive surgery? So why would you do a less invasive surgery when a talented vascular surgeon can do a very nice corpectomy, as shown in Dr. Abdul-Jabbar's case?
I mean, I think you could do an anterior open procedure as well. I think that's an option. I think it's probably a little bit more invasive. I think in my experience, if someone has spine mets and you do a posterior approach, it's very hard to do a corpectomy all posteriorly. So you have to try to figure out how to treat the anterior column, and doing a big anterior exposure is not without risks, and the vessels. And I think even, when you look at a case like this, it adds a significant amount in terms of morbidity. So I personally like doing lateral, but it's extremely technically very challenging because you're dealing with a lot of, issues that you wouldn't have to deal with, like the lumbar plexus. But this is a great example, and I like doing lateral for spine mets and cancer patients because they're able to mobilize and get up out of the hospital the next day.
Does it help you that we did a partial corpectomy to disimpact the neural elements? Is that helpful?
Yeah, I mean, that's one of the things that we do together. I think it's a game changer because it makes makes my retractor time less. And the less my retractor is open, the less chance for neurologic injury.
Abe, take us forward. So what was the next step?
So next, did the anterior column reconstruction like we talked about, the lateral approach, got a nice large cage with large footprints that spanned the end plates. We compare pre to post-op films, had a nice resection, nice reconstruction of the anterior column, maintained alignment.
So how difficult in terms of inflammatory reaction, that kind of a pseudo capsule of a cancer, was the approach for you? Is it easier to go through the muscles than anterior to the muscles? Because for instance, Dr. Hart likes to go anterior to the muscles with a different company's acronym attached to it. You tend to go through the muscle. Does that make it actually easier to get down to the target zone?
I think it theoretically, again, in my experience, I think whether you go anterior to the psoas or transpsoas, it's your experience and comfort level. But, I've gone anterior. I think for me, the main issue is the vessels. If I have a vessel injury, it's going to be very hard for me to repair that. I'm more comfortable with dealing with the plexus. So that's just been my experience as going transpsoas.
So two more questions. So first of all, in terms of pelvis crest, I know you're going to talk about that later, but this patient seems to have, to my simpleton eye, a low pelvis crest relative to the upper end plate of L5. If this vertebral body had been lower, are there some tricks that allow you to kind of still do this procedure as a corpectomy, or was this just a fortuitous circumstance that the patient had a low pelvis crest?
I think we evaluate all this before we decide to see whether they're a candidate or not. And you can actually see it on the pre-op. We study the pre-op CT very carefully to see where the crest is. I think this one, for getting in the 4-5 disc space, was borderline, in terms of trying to get access to it. But otherwise, I think it's you can easily access it from a lateral approach.
I do have to say I like the end plate coverage of this device a lot. This is in no slight on Dr. Abdul-Jabbar's beautifully done case, because that's probably perfectly sufficient. Is it hard to kind of cantilever this very long device in, or does the retractor system nowadays, if you're coaxial, make this very easy to put this kind of a super large cage in?
It's definitely tricky. What's interesting is that you can actually get quite a bit of lordosis, and because of the end plate coverage, I think the incidence of subsidence is less. And also, when you follow these patients long-term, the subsidence rate is pretty low. And it's amazing, you get fusion all around the cage. It's usually not through it.
So Dr. Hart always talks about that with posterior surgeries and then putting an anterior column construct. And maybe you first, rather than Bob. Did you, when you jacked open that cage, get lordosis? Because here, 4 rods in the back. We did whatever we could to hold this. We put cement around the screws. Did this still jack open?
You can actually, you've seen me do it. Even though it's fixed in the back, because the screws are multi-axial, you can actually wedge that open because the screws still toggle. And in fact, I've got some great videos that show it. You can actually get pretty significant lordosis.
So Dr. Hart, you've done something that I haven't seen before, and it's pretty impressive, but quantify that a little bit maybe. So you've done posterior scoliosis surgery and then gone secondarily anteriorly in your deformity course, and tell us when that's going to be, a little self-advertisement. But you're actually able to get further correction out despite rigid hardware in the back. Is that right?
So thanks for the shout out, and we should acknowledge our colleagues and team here at SSF. They've put together a great program. That's going to be this month, October 29th, so certainly would love as many in the audience as can join to join us for that. You're exactly right. Now for probably 10 years, I have been starting in the back. A lot of open adult deformity surgeons have moved towards posterior only, and I oftentimes will do posterior only and complete all of the inner body work from the back. But in patients for whom there's more extensive work required, we make a plan to do the posterior approach, get the decompression, get the stabilization, and then come back and plug in the inner bodies in the front to make sure we gain fusion. And I actually think of that more as just fusion rather than correction, but Rod is absolutely right. Despite even very extensive posterior instrumentation, when you get into the disc spaces in the front, they do move, and you can get some further distraction. Now, whether that increases overall alignment or changes overall alignment, I'm not 100% convinced, but there definitely is mobility, and I think that tells us something about why these posterior constructs oftentimes are not sufficient, and it underlines what we used to talk about as the benefit and the need for anterior column support.
Great. Okay, Abe, learning points for yourself for your own practice. And by the way, thank you, Dr. Boyer. So we will put the imaging up during discussions of constructs for the fellows also. So learning points for yourself. What are you going to do in your own practice?
So probably pre-op embolization is a good point that we brought up. I think that's going to help out quite a bit with blood loss, especially with cancers that bleed a lot, like renal cell carcinoma. can be, or prostate. Coming in from the either lateral and ALIF, I think is a really good approach. You get large cages, you get a good reconstruction. So I like that approach. And then like on here, we submitted the screws to give you a better purchase. I think is a good construct. And then also quad rod cross where you have a cage anteriorly, I think is a good idea.
I got to tell something to the audience and everybody. So there's a lot of titanium in the target radiation zone, and I've learned from radiation oncology friends that they don't like titanium in there. So this is actually a situation where we might want to consider PEEK or allograft, and the less crosslinks we can have, the better. So I know they're carbon fiber rods now, and we still don't have them here, but I'm still not sure that there's a actually convincing evidence to show longer survival or less local disease recurrence. But less metal around the target zones seems to be desirable for the oncologist's sake. Good. Thank you, Abe. Nice discussion. And next we have Dr. Mauricio Avila, and he has a different slant.
Okay, good morning. I'm also one of the spine fellows here at the Swedish. So for this case, this is a 60-year-old male who initially suffered a ground level fall 7 months prior to the presentation to the emergency room. During the fall, of note, he also suffered an elbow injury. And from that injury, 2 weeks later, he was diagnosed with an MSSA bursitis that was treated with oral antibiotics. He returned shortly, about 3 weeks later, to the ER. He was living outside of Seattle with some back pain and urinary retention. They put a Foley and gave some tamsulosin and discharged him. He went to his PCP. This was now about 3-4 months later, with still continued back pain, urinary retention episodes, and the PCP sent the patient to the ER giving back pain with red flags. Past medical history, he had anemia, and he works as a handyman. In the ER, he was awake and alert, he had a Foley in place, and as you can see from there, basically motor intact, no abnormal relief excess. I put some relevant labs there. As you can see, his anemia, he has elevated platelet count, and more importantly, his ESR and CRP are elevated. So I think we all know where this is going. This is his initial MRI that he obtained on the ER. Top left is a T1 non-contrast. The next one on the right is T2 with that axial showing at that level. And the bottom one is a T1 with contrast in the axial level. So as you can see at 2-3, there's a quite extensive discitis, osteomyelitis, also causing stenosis. This is his initial CT. Again, seeing the 2-3 discitis, osteomyelitis. You can see the severe end-plate erosion. Basically, L3 is maybe 50% of what L4 should be in height. Same with L2. And on the coronal, interesting, quite the kind of diagonal destruction of the disc space.
What's going on the coronal image mainly, but also partially visible on the sagittal image in the spine at the rostral end of the depicted window?
Talking about the lateral osteophytes?
Yeah, what are those called?
Syndesmal phytes?
Yeah, but that's a underlying disease process.
Oh,
that
DISH.
is-
You mean DISH? Oh, okay.
What does DISH stand for?
Diffuse idiopathic skeletal hyperostosis.
Aside from decoding the acronym, how does that affect our construct possibly?
It's a more rigid spine superiorly, which means that you want to make sure where you're going to end up is enough that you can cover the rigid spine.
To go into that rigid spine, because if you leave a motion segment there, it's just a fulcrum for failure. So this seems to be something that's a problem. Now we have one of our fellows, Dr. Jonathan Plumer, who's worked on trying to understand and quantify this better. Jonathan, can I just ad hoc have you come to the microphone there and just tell us a little bit about how you quickly assess some of the key parameters here in terms of severity? That's a nice composite slide, yeah. So this is the initial imaging obtained. Does that microphone work? Good. So Jonathan, tell us a little bit about what we should look at as clinicians and what in your evidence-based review matters in terms of predicting the best possible treatment or the outcome if we don't do something.
Yeah, what we put together in our score, or what we're trying to publish, is first we look at neurology, but I mean, we have an assessment already. Then on the location where it's located, and in this part, or in this case, would be a very mobile part of the spine. So, and close to the thoracolumbar junction. So this is very important, and also if we go to the to the CT, or we see some significant erosion and loss of bone due to the infection. So this is a very important part too. In this part, it's even more than 50% of the vertebral body. So, but we can also see some spinal stenosis due to the infection itself. So, which is basically the most important part. And last but not least, comorbidities and also the pain itself are a big issue. So that's what we basically are looking for in our scope. We hope to publish this soon. So
What comorbidities matter? So there's a lot been bandied around, and just give us what are the two leading comorbidities that really have statistically been shown to matter as an adverse predictor for outcomes?
Yeah, for de novo infections, we mainly find diabetes and also IVDU. That means intravenous drug abuse. Are the only ones with statistical knowledge or a statistical basis that kind of matter.
So Mauricio, in this case, what applied here? What were the risk factors as you look at this horrifying case?
His risk factor was anemia. And actually going back and looking at this case, I think one thing that initially I guess I personally didn't know when we look at all these cases, what he actually had a bursitis of his elbow initially 7 months prior, which I think, because he's not an IV drug user, his urine toxicology was negative, and besides anemia, his BMI is normal, no diabetes. So I think that was the original, how the bacteria came in, and then this has been like a slowly infection brewing in his spine.
Now tell us a little bit, so you come from the University of Arizona, and one of your faculty members, Dr. Huang, is watching you carefully, so watch out what you're saying. But you've been here for a couple of months now. Is there a difference in the amount of infections, de novo spine infections? So with stories like this, can you go back to the images that you see? Or is this a geographic outlier here, or do you have the same problems in Arizona?
Well, I can tell you that personally I thought we saw a lot in Arizona, but then here is like out of proportion, especially as Jonathan was mentioning, when we do our research meetings and the amount of patients you're able to gather here, I think is just out of the norm.
And if you try to wager a kind of a comparison, a causality, what's different here?
I can tell you, Tucson being more like a retiree community, we see a lot of older patients, frail patients that have infections. We also see IV drug user, but I think here is mostly the IV drug users that we see fairly often.
Okay. All right. So infection, Dr. Plumer gave a poor prognostic outlook for this patient if we don't do surgery. So what happened?
So he initially went a disc biopsy before getting transferred. By the time he got here, we only had what was well blood count on the smear, but no bacteria yet. And again, as we were talking, given progressive back pain, urinary retention, stenosis, erosion of the end plates, and the suspicion of the infection, we recommend the surgery. The discussion, which is relevant for today, is it all posterior, laminectomies, and fixation, interbody, corpectomy, lateral corpectomy and per screws, or a combined approach.
There you go. That's nice, comprehensive. Okay, show us a picture.
So this was a stage procedure. Try to put some intra-op images that were available and the post-op CT. So he underwent initially a T10 to pelvis fixation with laminectomies from L2 to L4. And as you can see on the top left, that's the cannula in the disc space for washing out the disc. That's a Dr. Chapman special with I think it's a thoracic cannula you use to wash out the disc. And then the one below it is you see an osteotome doing a partial posterior corpectomy of that infection, which you can see on the post-op axle on the top right corner. So this was stage one. And then on stage 2, we did a lateral, removal of the remnants of the vertebral body and placing out of expandable corpectomy cage from a lateral approach. That intra-op image there is just the retractor in place. And then you can see the post-op CT scan with the cage in place.
So, Dr. Hart, you've published a very nice paper on that. This looks like overkill in your paper. I mean, you've just washed out the disc space and posterior stabilized them because, as we all know, infections can heal once they get past the inflammatory stage and turn anabolic. So, is this overkill in your eyes, or is this a reasonable treatment?
Well, I would say no, it's not overkill. So you're referring, the paper you're referring to, actually, it was Alex Ching's work at OHSU, and but that was really a different set of patients that had not had severe erosions of the end plate like this, and those were mostly thoracic levels as well. So it was percutaneous stabilization, which I still do in some situations around a discitis. And the fusion rate, the auto fusion rate there is fairly high. It will fuse across the infected disc. And then the intention there then is to remove hardware down the line once they're through the infection and through the fusion process. But in this case, the two things that argue against that, well, I'll say three. Number one is the extent of the bony erosion that's already present. This is not going to heal with just percutaneous stabilization. The location in mid-lumbar or upper lumbar spine is also mechanically less favorable. And then maybe the main issue is what you've already pointed out, the autofusion due to dish and the thoracolumbar junction really requires this kind of pan-lumbar fusion, in my opinion.
Rod, thank you. Appreciate that discussion. So how hard was it for you to get into this inflammatory zone for a lateral exposure? Was that difficult? I mean, we know that getting into the front of an infected spine can be a nightmare.
Yeah, I mean, I think that if I remember correctly, the patient had a psoas abscess as well.
Yeah.
So I think, usually there's a significant amount of adhesions, and so you kind of have to develop a plane. But once you develop a plane, it's actually fairly straightforward to get in. The abscess almost forms a natural corridor that you can go through. And on this case, I think there was a pretty significant abscess in the psoas. So once we got in the plane, we got right in the disc space, and you did a beautiful posterior corpectomy. So the nice thing about going lateral is the access, once you get it, it's very quick. I mean, it doesn't take us more than like an hour to drop the cage in.
How did the patient do, Mauricio?
He actually did very well. So the surgical pathology, confirmed that it was actually osteomyelitis, as you can see there. He underwent 6 weeks of nafcillin, and as our ID doctors love it, rifampin, just for the suppression. And then his back pain improved, and the Foley was actually removed in the inpatient rehab once he was discharged.
So favorable outcome.
Favorable outcome.
Did you treat these osteomyelitis cases this aggressively in your home institution?
With antibiotics, yes, we always try to go, minimal invasive or IR guided disc, and then usually try as much as we can to not, perform surgery if able. It's also because some of these patients, it's hard, as follow them up and et cetera, et cetera. But once the back pain is severe or neurological symptoms, I think it's your hands are tied and you have to intervene.
Good. Thank you. We have one last case, I think, before Dr. Oskouian's presentation. Dr. Chris Seidel is coming. He was hiding. And this is a different slant on the topic. And I'll give it away, Chris. It's an infection again, but there's a couple of wrinkles to it. So I appreciate everybody being here this morning. And I thank our fellows for their hard work, not just clinically, but also putting these presentations together, and all of the discussions and our online viewers.
Yeah.
Right. So this
Yes.
patient,
Wait 1 second. Dr. Uribe, do I hear your voice?
Jens,
Oh, Tariq.
Yes.
Good afternoon.
what was
to you. Good
culture
morning.
about any bacteria grown out of this granulation tissue, any kind of
Hi, Tariq. Good day. So Dr. Avila, come here. Tell us again what the bacterium was.
MSSA, so the same one that he had in his elbow. So insulin sensitive staph.
So to me, it appears that the dead bone is still there even after surgery. Do you anticipate that it will not flare up again?
I think this will heal nicely. In our experience, you don't have to do a radical corpectomy. In the dead bone, as you call it, if it's a sequestrum, it'll be a problem. But this is still all soft tissue attached, so I think that there's a chance for revascularization. So we've usually, we basically want to have all dead tissue with reasonable radicality removed. And we want to have a stable spine with decompressed neural elements and a physiologic alignment. But we've not done radical corpectomies. Do you think differently?
No, I think
Corpectomy?
I think it's a job well done. They have removed most of the scastum. They have removed all the granulation tissue. What I think what is required is a good amount of, short of radical debridement, in which you remove all the granulation, dead and dying tissue, and whatever is left probably is attached to the soft tissue. And I think it must have been carrying, or it will carry some blood supply to the dead bone. Hopefully, if everything stays clean with antibiotics and etc., it will revascularize and it will restabilize itself over the period of time. I think if I were to do, I would have done from the front as well, because it doesn't take very long. And I think you can do the better debridement from the front.
Yeah, no, I mean, that's a very reasonable argumentation. I think we talk about a lot of the same principles. The details are probably different. I want you to stay online for this case because your insights here will be particularly relevant. So hold your thoughts. Dr. Seidel.
Sure. Okay, thank you.
Okay. So this patient I'm presenting was a 33-year-old male from Indonesia. He was working on a cruise ship line that was docked here in Seattle. He complained of several months of low back pain, right leg pain. It was progressive in nature. No history of IV drug use, no bowel bladder problems, no saddle paresthesias, no fevers, chills, night sweats. He was a smoker. On exam, he was neurologically intact, but had a right straight leg positive test. CBC normal, CMP normal, elevated ESR, CRP, normal lactate. We didn't have plain films, but we had our scout from our CT, which I included here, just to show that he has no deformity present at this time. So here you can see that he's got a destructive osteomyelitis. Primary focus is the L5, S1 level, with a secondary focus at L4, L5. There's a large epidural and prevertebral purulent collection. I'll just let these play through for a second before I move on.
So no neurology, straight leg raise test, unable to stand straight due to pain.
Yeah.
There's kind of an escape posture.
Progressive low back pain with escape posture.
No braces, no previous treatment, no major risk factors outside of being a smoker, and is a relatively thin man.
Correct. And here on CT again, you can just see those destructive lesions, mostly affecting the L5 level, but also the upper end plate of S1 and to a lesser extent L4. And again, I'll give this a second to play through.
So substantial, this looks like a chronic process, if I'm editorialized. There's sclerosis, there's lysis, there's some marginal reaction zones of the host. What makes this look like an infection versus a oncologic process? A very simple question, Chris, and I love how you put these videos together. It's very nice. So why does this look like an infection to you immediately and not a tumor?
It spares the disc space.
Disc space, bingo. So, all right, so no chest involvement?
Yeah, so there's obviously, because you just mentioned that there's no disc space involvement, this is very concerning for possible TB. There was no obvious involvement in the chest CT. IR did do a biopsy, which revealed no organisms, but they weren't able to include an AFB because they didn't get enough tissue. But obviously the red flags were there that this could be Pott's disease. So discussion was had with him versus surgical versus non-surgical with anti-tubercular therapy.
Ultimately, the patient elected to undergo surgery. So we performed a decompressive laminectomy L4 to S1, subtotal corpectomy L5, partial corpectomy.
Pictures, go to the
Okay,
pictures.
let me
We
just
don't-
fast
Good.
forward ahead then. So here's post-surgical CT. And I've got videos for both. So he got bilateral expandable cages after extensive decompression and corpectomy there.
So we're at the L5 body. Tariq, so we went from the back, we did nerve root sparing, bilateral cervical cages that we inserted between the nerve roots at the interval of 5-1. So you put them in horizontally, then turn them straight, and then turn them around and distract them. This is Pott's disease. Tariq, are we crazy to instrument this? Won't this heal by itself over a couple of months? What would you have done, Tariq?
I think I could have done similar what he has done. And I think I would have gone from the back and put up 2 screws in the ilium rather than 1, and I would have spared the S1 pedicle, and I would have done the debrima. I would have sent for culture sensitivity. At the same time, rule out any other metastatic deposit, which I don't think so. It's a metastatic in origin, and would have put a stud graft, either titanium or the host bone tricortical iliac crest, whichever would have been available to me. And I think then carry on with the broad spectrum. Once a culture sensitivity and histopathology comes back, I could have resorted to appropriate treatment, whether it's anti-tuberculosis, it's a TB, or any appropriate antibiotic, which culture sensitive would have, told us.
Tariq, did we take out enough bone? Did we clean up enough?
I think I would have done a little more, but again, going from the back, you are working in a sort of rather obscure area, which is not very visible. But I think you can still remove a lot of bone with the curate, and you can make sure there's no loose fragment there. And once you make sure that there's no loose fragment and disc above and below is adequately taken care, then you can put a bone or the bone graft or a cage with a bone graft, whatever he has done, it seems adequate.
Rod.
But I think I would have removed a little more bone as compared to what has been done so far. I would have tried to remove as much loose fragment as possible.
Can you access this from a far lateral approach or anterolateral approach?
No, it would be almost
L5 is a no-go zone still, right?
It's not going to be able to go.
So in your experience, do we have to take more bone out for infections, or is it okay if we leave viable looking bone that's attached to soft tissues intact?
Honestly, I haven't had an issue. I think you discussed it. I mean, you get this huge inflammatory response, and if you get, most of it out, it actually fuses like mad. Mm-hmm. I think if you stabilize it, I think the old orthopedic principle of, for infections applies here. If you stabilize something, it fuses.
Dr. Hart, again, if we don't want to gang up on Tariq, you previously mentioned this paper where you at OHSU in Oregon just did a relatively small debridement and stabilization. So how much do we have to take out in an infection?
Well, again, this is a very different pathology than what we were really describing in that paper. But I agree with the overall comments. You certainly don't want to leave a sequestrum behind, something that's totally devascularized and full of bacteria. But you can leave bone attached to soft tissue as part of the debridement. I'm a little surprised. This is beautiful, by the way. I would probably have done this as posterior anterior and come back and did a vertebrectomy from the front with an approach surgeon through a straight anterior approach. And if you elect that, this is a case where you have to make sure that the approach surgeon is aware and takes the iliolumbar vein as part, in order to do a corpectomy from the front at L5. I had one case early in my career where the approach surgeon and I at that time was unaware, and we stood there for an hour with a sponge stick on the iliolumbar vein after completing the corpectomy, waiting for our vascular colleague to come and rescue us. And ultimately, thankfully, that patient had a good outcome, but that's not where you want to be on a Sunday night, I can tell you that. So
Would you agree L5 corpectomies are a daunting procedure because you have to dissect out the bifurcation,
Yeah.
top and bottom, and mobilize the tree either through the bifurcation or from lateral, whatever is possible.
Not for the faint of heart and not to be done solo, I'll say that. One thing I wanted to point out or ask about, I'm a little surprised none of these cases, these two infection cases, neither of them had a cement spacer placed, which is probably what I would have done here. I would have done a large amount of the corpectomy and then placed an antibiotic-filled cement spacer into the vertebrectomy defect and come back a few weeks later and completed the corpectomy. I know you like that procedure as well. Why did you choose not to do it in these cases?
Very good point. So this is a gray zone, and if I had a predictable long-term outcome in this patient, I would probably do a cement spacer here. But this patient will never be seen here again, probably, so I wanted to give him the best possible chance for healing. The previous patient, again, we felt that we had a very good debridement, but if I have a patient who is cachectic, depleted, like what Amir showed earlier in this burst fracture patient, I would probably stage the surgery also. But access here is a big deal, and again, getting into that L5 space, this is a hard enough procedure, right, Chris?
It was very difficult to get the cages in between.
The nerve roots, and he was actually intact afterwards. He had some numbness, but these are not simple cases either which way, but I'd prefer not to go back into that space again. But I still don't have a scientific differentiation. A cachectic patient with a lot of a very poor albumin. He had actually a pretty good albumin level from what I
his
remember.
nutritional labs were good. He was very healthy otherwise.
Right. So there I feel more confident that the body will respond.
Yeah, this makes sense. And, I kind of had a sense from your first slide, Chris, that this was going to be TB, and the things there, first of all, Southeast Asian background, second of all, a young person, third of all, works on a cruise ship, and then the radiographic appearance obviously sort of completed the picture. But just for the fellows' awareness, TB is considered the first orthopedic disease, right? So the first orthopedic surgeons, and this is also for our neurosurgical colleagues, but spine and hip and peripheral skeletal surgery, the first reasons we began to do that, by and large, were infection, and by and large were infection with TB. The second disease was polio, and now the third orthopedic or musculoskeletal disease is degenerative disease, and that's the era we're in now.
Very, very nice perspective. Thank you. So let's go to the main feature today. We had a couple of appetizer cases. Dr. Oskouian does not require an introduction, but it should be pointed out he's an amazing trailblazer in many regards, and far lateral procedures. He's one of the originators of that. And we have Dr. Uribe on, I think. I'm not sure Dr. Pimento's on, but we have a great faculty here to discuss this. Getting through to the spine from a far lateral approach. Where are we now? And you saw some of those boundary situations. So Rod, educate us in your more recent insights.
Yeah, so thank you so much. So actually, this is a great topic because it really kind of illustrates a lot of the things we discussed. And it's kind of a 15-year journey for me since coming to Seattle, working at Swedish, and working at this amazing facility at Seattle Science Foundation. Here are my disclosures. Again, for me, the most important thing is why even go lateral in the spine? And, when I was a resident back in 2006, the lateral approach was sort of starting to take off, but again, not really there. The instruments were very crude. We really didn't even have any neuromonitoring. And I remember when I first was learning how to do it, I was like, this is crazy. We're never going to be able to navigate this area. But I was intrigued because, it had a perfect corridor. And just in terms of minimally invasive surgery, it was everything that I thought minimally invasive surgery would be, which is less blood loss, minimally disruptive. You're not cutting a lot of muscle. And you're dissecting through the psoas, not cutting the psoas. The downsides too are excessive fluoro exposure, very difficult anatomy. It's a steep learning curve. You have to do 50 to 100 lateral cases to get really comfortable doing it. And again, in my training, the retroperitoneum, this is probably for urologists and general surgeons. It's something we're not taught in neurosurgery residency, and this is a great depiction actually from SSF. We've taken away all the peritoneal contents, and this is where you're dealing with. So if you're going to do an anterior approach at 4-5, good luck. You do corpectomy at L5 or L4. Here's what you have to deal with. And again, that's not showing the intestines and the retroperitoneal content. You have to move all that or go transperitoneum, which is, again, it's a nightmare. And so for me, it's all these things, but it's something that I, as a neurosurgeon, was never trained in. This is like, who's ever seen a kidney? I mean, I've never dissected out the kidney or, looked at the retroperitoneum in such a way. So I spent a lot of time here at SSF, and a lot of the pictures here will be from our lab. And, these are some crude pictures. These are old anatomy books, and you can see the plexus. It's just basically a cartoon character of what it actually looks like. And when you dissect it out, it's extremely difficult to dissect out because it's actually within the substance of the psoas. So when you dissect it out, you're disrupting a lot of these. There's lots of interconnections that go through the psoas that people don't talk about, and that's what gets injured when you do lateral surgery. And again, this is from my medical school days at UCLA. We'd study the brachial plexus. You'd have to do the trunks, the cords, anterior, posterior divisions, all these things. We never had to memorize the lumbar plexus. It's not even discussed. It's in one corner of, in my anatomy book at the time, and we used Clemente's atlas, who was one of the anatomists at UCLA. There just wasn't very much known about it. And since I've been in Seattle, we've done a lot of work in it, mostly here at the Seattle Science Foundation. And this is a beautiful 3D reconstruction that's been done on a 3T MRI and then reconstructed and then slowly put back together with the different, the psoas muscle. You can see the pelvis there. And again, each patient is going to have, different anatomy. So every single patient is going to have different anatomy. And when you look at two people, they could be genetically related, right? But they're going to be different. So this is Dr. Chapman and his cousin, and there's some similarities there, right? But their lumbar plexuses are going to be very different. And it's astonishing to me how different each human is, male, female, size, BMI, all those things make a huge difference. And again, these are some pictures in the lab. We put some sheaths into the plexus, and then this is a lateral view, and you can see how treacherous this is. And then we put some K-wires into the disc space and then dissected it out, and this is what that looks like. After you dissect it out, you can see how close you are. There's the kidney, there's all the, again, we've dissected out the plexus. And this is actually, I think, one of the most beautiful real 3D reconstructions of the plexus. You can see how complex that is, right? And I remember when we were doing this, we'd bovie, stick our finger in, start, but these are all motor and sensory nerves that you have to go through in order to do this. And when I started doing lateral, I actually started doing in the thoracic spine first because I felt more comfortable. I couldn't understand the plexus, the neuromonitoring wasn't great. And each time I did a case, I actually, when I started doing lumbar cases, this is a beautiful depiction of it, is that I would actually use a microscope, go down, find the femoral nerve, and then put my retractor anterior to it. That's how I learned how to do lateral surgery. And it took me a long time, again, I know we talked about corpectomies, but this has taken me 15 years to be comfortable to do corpectomies. So for me, understanding these relationships is super important, and knowing, where the plexus is. And again, what's interesting, the plexus doesn't move that much, right? It's fixated in the lumbar spine, into the psoas, so you're not going to move it. And mapping it out during surgery, which is what I'm doing here, and I actually try to find the femoral nerve. You know, I want the monitor to start alarming red, 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 that you're close. If you don't start mapping it out and you don't understand where the plexus is, that's where you get plexus injuries. And again, with corpectomy, especially, we're going to talk about L4. I try to get into the disc space of L3-4 first, and then walk myself down. And you can see that corridor. I try to land my retractor right in that sweet spot. And again, usually it's about anterior 2/3, and then I'll cheat forward. And here's another beautiful 3D reconstruction that was done by actually two of our one of our fellows, Perry, and then Angela Tran, actually, who works here at SSF, did this beautiful job of painting the nerves and the muscle and reconstructing this. And then this is both anterior, lateral view, and then looking anterior and then looking posterior. I mean, you can see how, I mean, this is extremely treacherous, and this is what we're dealing with. And again, most MRIs, CT scans, you're not going to see the lumbar plexus, right? But you have to know that it's there, and you have to understand these relationships. And my learning points from again, doing lots of lateral is that it took me a long time. So when you get out in practice, you shouldn't be doing L4 corpectomies. That's way down the road. You know, we learned a lot, you know, from our anatomic studies. We learned the relationship of the femoral nerve, and you really have to study the preoperative imaging, CT scan, MRI. You know, you have to go back to that picture that I showed originally where you look at the great vessels. You can actually see them on an MRI. Most MRI, CT scans, you can do 3D recons. You can see the iliac vein, iliac artery. And again, I started doing thoracic lateral before I did corpectomies, before I did lumbar, understanding the vertebral body's smaller. You know, you can do a lot with the retractor. And then I started, again, when you do lateral, I did thoracic, then I did lumbar, I did thoracolumbar. You know, you get comfortable, then you deal with the plexus, and then you can deal with the lower lumbar spine. And here's some case examples I did early on. You know, here's a thoracic disc, and you know, it's a very challenging case. Patient has had multiple lumbar thoracic lames, and then I went lateral and it went all the way across. But learning how to do this helps you prepare to do a corpectomy. So you create this long channel. I didn't even try to take the disc out. I just cored out the posterior wall, and then I let the cord go anterior. But it's like sports, you know, you want to do the smaller, easier things first. And so learning how to, you know, manipulate the retractor, you can see that there, and be able to work your way back towards the canal, going all the way across the vertebral body. And in the thoracic spine, the thoracic vertebral bodies are much smaller. And then I started doing cases in the thoracolumbar junction. And again, this is a case I think early on. Jimmy, you showed that case. Here's a fracture that, you know, we think is all benign, but then, you know, it becomes this. And, you know, how do you manage this? Well, it's going to need surgery. You know, if it would have been treated earlier, probably not. And these are great cases, you know, again, as you build your confidence, you know, the plexus isn't here. You're not dealing with a lot of the issues that you have to deal with in the lumbar spine. So I started doing these, you know, trauma, thoracolumbar junction, and here's what you can do. You know, you can do a beautiful lateral, get good reconstruction anteriorly and go posteriorly. And then you start understanding how to do these procedures. So for me, do thoracic, then do thoracolumbar. Here's some thoracolumbar cases that I did. Here's a revision case. And again, you know, don't start doing L3, L4 corpectomies early on. Do it later when you feel more comfortable. You understand, you know, how these anatomical relationships work. And then you can do a case like this. This is a METS to L4 patient had colon cancer. And I like doing, these minimally disruptive lateral approaches for cancer patients because they get out of the hospital, they don't get an ileus, they don't have a big anterior surgery. And you can, I think Amir's case was great too. You can do just one level above, one below. You don't always have to do a big surgery on a patient with cancer. And again, when I look back, what are the other advantages? Well, you don't have to have an access surgeon. You don't have to mobilize the vessels, and you can do smaller incisions. And I think with lateral surgery, there isn't enough, it is truly minimally invasive surgery. And again, if you think about doing an anterior approach, it's pretty morbid. It's not, it's not a benign procedure. And Dr. Hart was kind enough to give me one of his cases. So you can see, I mean, there's like 6 hands in there. There's Dr. Hart's hand. I mean, this patient was in the hospital for a long time. They hurt. We used to call them shark bite incisions. Why do they call them shark bites? Because it hurts like hell, and you look at the scan afterwards, you're like, oh, we did this beautiful. And the patient has, abdominal hernia, they hurt, they have a bulge, they're complaining, it looks terrible. Dr. Hart, can you do lateral surgery, please? And you can see there's my incision. It's a tiny little Band-Aid. So what would you rather have, that or that? So it just, and again, it takes a long time to get to this, but once you feel comfortable and you can do it, that's literally the size of the incision. And you can get a lot of correction just going lateral. Here's another case I did laterally. You can see how kyphotic it was before and how much correction we got by taking out all the anterior column there. And here's another case that we did. Here's a metastasis case we did. I did just one level above, one level below. And here's what the final construct looked like there. And here's another, again, kind of working yourself, thoracic, thoracolumbar, do L1, L2. Then if you feel comfortable doing L3, like this is a great case that we did at L3. Here's the approach and the final construct. We just did one level above, one level below. And retractor placement, and this is actually one of the cases that I think Jens and I did. You can see, I mean, you can get a pretty nice, very large cage with very long end plates and get very good coverage. And you can see, the retractor placement is key. So you have to map the plexus, know where the femoral nerve is, and then where you place your retractor is where your cage is going to end up. So you spend a lot of time, doing that, and then you'll end up placing your cage, and your final construct you'll be able to get a nice sizable cage in there. And I can't stress the importance of preoperative imaging. You can get, these are just from some of the cases I did. Look at the diaphragm. You can see everything on this image. You can see the kidneys, you can see the great vessels. You can scan through these images. You can see the iliac crest. Like on this case, I was worried about several things. Am I going to be able to get to L4? What's the vessels look like? I always look at that. And then, you look and say, okay, and then you can actually measure the size of the end plates preoperatively. So you go, okay, this is going to be, for example, this was, I think, a 50 millimeter. So you can measure, and then the length of the end plate, and then the size of the cage. So you're not guessing, everything's ready to go. You drop your tractor in, and then you're able to go in and basically put your cage in and do your final construct. And again, this is another patient with metastasis. And most patients with metastasis, guess where they have the first place it goes to? It goes to their spine, and it goes everywhere. So here's a perfect example. This patient, I think, ended up, patient had, I think, ovarian cancer like 20 years ago, and then ended up, and you can see she's got lesions in her pelvis. So if you can go lateral, maybe you can do something smaller. You don't have to go to the pelvis all the time. And for cancer patients, this is a great approach, and again, this is, you can see here, it's mainly L3, and she had those lesions in her pelvis. What if you could just go lateral, not have to use an access surgeon, not do a big exposure from the front, do a huge shark bite incision on this frail cachectic lady, and then what if you can do something small? This is a game changer for a cancer patient. They can get CyberKnife, they can get radiation, they can get chemotherapy. This patient was in the hospital one night and end up doing great. And then here's her X-rays, a year out. So to me, this is when people talk about robotics, minimally invasive surgery, you can't beat, this is incredible. This patient is so grateful, and she's done great. She had her radiation to her pelvis, and she had her spine radiated, and she's done terrific. And here's some more challenging cases. Here's another patient who actually had mesothelioma. And again, same thing, he had Mets in other parts of his spine. We did the surgery and again, went home the next day. And here's the final construct on him. And then here's, again, you can see how much tumor there was before surgery. And he had Mets everywhere else in his spine too. So he ended up getting radiation. But, these are the kind of, cases you can do. And the patient's minimal blood loss, minimal exposure. And you can see here, this is a huge advantage for these patients. And here's the patient's X-rays. They're now almost a year out, and you can see there's not much fusion, but the construct is very stable and ended up getting radiation afterwards. The key thing for me, again, is just understanding anatomy, studying the preoperative imaging, and you can do all these great cases. This is another great case. You can see how much lordosis the patient is going to end up getting at the very end, just from doing, a corpectomy there. And you can see how much end plate coverage we got. And as you feel more comfortable, you can start doing these cases, revision cases. This is a case actually Jens and I did where the cage had fractured, had gone back. And this is always a bad sign if you can see the cage, if the cage is looking at you like that. So we did it together, and I went in and actually cut the cage. Jens, I think you remember this case. And then look at the CT myelogram before. And, we did it, and actually it was ironic because she had a shark bite incision way in the front, and then we went even posterior to that, so you don't even have to go through scar tissue. We ended up, so the post-op images are there. And then we recently, just in the last several years, this took us 15 years to write this up, but we finally wrote up our experience and published with Seattle Science Foundation this great book on the lumbar plexus. And hopefully, and surprisingly, shockingly, it's very popular. It's actually very popular in medical school. So TIMA published this, and it's taken off like crazy because there's just no textbook. I think this is the only textbook on the lumbar plexus. And TIMA's asked me to write another book on it. But it's amazing to me. You think, okay, here in anatomy, we've been studying this for thousands of years. No one had ever written a book on the lumbar plexus. So I want to thank all the staff at SSF and my colleagues and who helped me through this journey, and my family. And it's been a great experience. And again, these are extremely challenging cases. And you can do L4 corpectomies, but do the easy stuff first before you start doing L4. Thank you.
Amazing perspective. Can you go back to that lumbar plexus thing? Yeah, this is great. So, first of all, this is a really good book, and I know you don't get any financial compensation, so I feel very comfortable endorsing this wholeheartedly. You said two things that I want you to just illustrate a little bit. So pre-op planning using imaging and mapping. So specifically, what, in a very nutshell thing, do you look for that will preclude or invite you to go in from a far lateral approach? Specifically, there's a term that I've learned now that I never thought would apply to spine, Mickey Mouse ears and pelvic obliquities. So what is a clear no-no for you, what you're studying at, or is it just technical? And what does mapping actually mean?
So those are great questions. So for me, the whole issue with like what the psoas looks like on an MRI is really not that helpful. That's more, I think, for OLIF, people that go anterior, and they try to look at the relationship between the vessels and the psoas. And so for me, that's not that important, but mapping it out is the most important. But what I mean by that is that you basically, whatever, again, all the companies have great neuromonitoring, but you can go in, stimulate the psoas, and then when you find the femoral nerve and all the different branches, then you can feel comfortable doing the approach. And again, sometimes when I do these cases, I will abandon the neuromonitoring and I'll just bring a microscope in. I'll go and find the femoral nerve. And I think, Jens, you've seen me do this. And then I'll place my retractor anterior to it. So that's what I mean by mapping. It's like if you're doing a brain tumor in an epilepsy case, if you don't know where speech is, you don't know where, Broca's, Wernicke's is, you can't take that piece of tissue. And the same thing works in the lumbar spine. If you can't find, where the plexus is and you don't know where the sweet spot is, I'll show you on this, actually a great image is, you got to find the sweet spot. And for me, finding this sweet spot, which is about this area, if you can't find those relationships, then, I think that's, to me, the most important thing. So, Bob.
Okay. Yeah, Dr. Chapman had to step out for a phone call, so I guess I'll sit in for him here briefly. That was a fantastic talk and so much content and a couple of questions or issues I wanted to call out. Before that, though, I wanted to say that photograph, I can absolutely verify those were not my hands, because my hands are much knobbier and those were very delicate and small hands. But let me say also further that I'm glad you were able to exercise some of your demons and insecurities here in a therapeutic session. So some humor between colleagues. And really, the collegiality here is just one of the high points of this program. And it's been a delight being here with you guys the last 6 years. I can't believe it's already 6 years. But to get back to the content, so first of all, I wanted to say a straight anterior approach that you do typically to L5-S1 can do to 4-5 or 3-4 or even 2-3, much less morbid than the lateral shark bite approach that we used to do. And that absolutely was, to do a lateral approach to several discs from L1-2 through lower lumbar, absolutely a morbid procedure, certainly best avoided. And Nuvasive first came out with the XLIF approach. That was something that I saw as absolutely a game changer, and that has turned out to be the case. I now do the lateral approach as low as L4-5 in some cases. I still have not waded in on trying to do 5-1 through a lateral approach, although some surgeons are doing that. But the approach that I now do, I call trans-anterior psoas. So meaning I don't try to stay fully anterior to the psoas,
Sure.
but in the anterior centimeter or so, I think it's typically safe. And what I did find with the straight lateral trans psoas, I had one patient at L4-5, I remember, that got a femoral nerve palsy and really was affected by it and unhappy as a result. And that kind of drove me away from a straight trans psoas approach at 4-5. I think you can typically do it very safely above 4-5. 4-5 is the treacherous level. And is that consistent with what you found anatomically?
Oh, yeah. I mean, 4-5, there's no question, you know, and I think, you know, this actually image here, you can see on that one view, you can see that's actually the disc space. You can see all the branches, you know, coming off right in there. So that's where, you know, you're going to run into problems. So great. Thanks, everyone.
All right, thanks, Rod. That was a fantastic talk.
Lord,